So, it gives me real pleasure to introduce the last speaker this morning, Dr. Larry Kvols, who's Professor of Oncologic Sciences at the University of South Florida in Tampa, Chair of the Neuroendocrine Section at the Moffitt Cancer Institute, and Chairman Emeritus of the North American Neuroendocrine Tumor Society. Dr. Kvols has spent at least 30 years in the area of neuroendocrine disease and really was the lead and pivotal point of all the early research on somatostatin analogs. My contact with him was when I was a student at the Mayo Clinic, where he was a real mentor to me, not only both for his research capacities, but also his communication skills and clinical acumen. As well, when I was a fellow on his service, I remember him asking me if I could just run the service for him one weekend because he was going to a Bruce Springsteen concert with his kids. I can only hope now that my kids are 11 and 14 that they welcome me to their concerts as well as they must have welcomed him way back when. Dr. Kvols. Remember to fill out question cards.
Thank you, Danny, for that kind introduction. My first visit to Halifax, I've had a wonderful time. I brought the sunshine from Florida. I got here Wednesday late night, and Thursday was a miserable day, but I had fun anyway. And yesterday I took advantage of the sun and drove up to Halls Harbor and watched the amazing rise in the tide, and then went down to Lunenburg and Peggy's Cove. What a beautiful country this is. I'll be back sometime in the fall with my wife. The title of my talk, A Journey in the Land of Small Tumors, is a takeoff from an editorial I published in the Journal of Clinical Oncology. 3 years ago, they were celebrating the fact that this premier medical oncology journal was celebrating its 25th anniversary. And Charles Mortel, who was my mentor for 20 years at the Mayo Clinic, had published an article back in 1983 called Treatment of Carcinoid Tumors and the Malignant Carcinoid Syndrome. Since Dr. Mortel had died, and I'd worked with him for so long, they asked me to write the accompanying editorial as they republished this article. And it's one of the most fun papers I've written. It was delightful to see the keen insight that this brilliant guy had. And he had written a paper, again, in the Journal of Clinical Oncology called An Odyssey in the Land of Small Tumors, and that's why I titled it Revisiting C.G. Mortel's Land of Small Tumors. So the goal of my talk is to primarily focus on two molecular targeting agents. One is called somatostatin analog octreotide, and within that we'll discuss the recent publication of a landmark study called the PROMED trial. And then I was just at the FDA about a month ago, and we presented the results of the everolimus or RAD-001 trial. The trade name for this product is called Afinitor, and the committee voted 10-0 to approve it, and the final package insert was approved this week, so it should be ready for marketing in just a very few days. If time allows, I'll speak about peptide receptor radiotherapy. Although that was covered so nicely this morning, I won't feel bad if I cannot cover it. So just a word on prevalence of these tumors. Incidence means how many cases occurs per 100,000 patients, 100,000 people, I should say. So for carcinoid tumors, that's between 5 and 8 per 100,000. So for the patients in the room, you're a rare entity, but these people live a long time, strikingly longer than people who have stomach cancer, pancreatic adenocarcinoma, hepatocellular cancer, and esophageal cancer. And for that reason, the prevalence, which is how many cases are present at any one time, not how many are occurring per year, but how many are alive and seeing their physician. The prevalence of neuroendocrine tumors is higher than any of these other tumors. That means in a busy GI cancer clinic, I will be seeing far more patients than my colleagues who focus on gastric cancer, esophageal cancer, and so forth. So that's the good news here, is that the prevalence is high because the survival is so much better, and it's gotten dramatically better, as I'll show you toward the end of this talk. What I'm going to do is just jump right in, now that we've touched on the prevalence, to systemic therapy. In 1984, I had the great good fortune of being the first individual in North America to evaluate octreotide. At that time, it was the first somatostatin analog that became available for clinical use, and we started a trial when I was at the Mayo Clinic, and the results in the first patient were so dramatic that we rapidly developed a phase 2 protocol. And that phase 2 protocol resulted in the first New England Journal of Medicine publication in 1986, where we demonstrated efficacy in 25 patients and subsequently expanded that to 66 patients. And I'll give you some of those results in just a moment. What does somatostatin do? You and I have it ubiquitously distributed in our bodies. It's present in our pituitary, it's present in our thyroid, it's present in the stomach, the pancreas, and the small intestine. Its effects in the GI tract are summarized here. It reduces blood flow to the liver. It inhibits gallbladder contraction, and that results in one of the side effects, and that is the formation of sludge and stones in the gallbladder. So when we see a newly diagnosed patient with a small intestinal carcinoid, and we're going to do surgery to resect it or to deal with liver metastases surgically, we'll ask the surgeon to do a prophylactic cholecystectomy so that 3, 5, 8, 10 years down the road, the patient doesn't have to have another surgery to remove the gallbladder. I've circled here the things that somatostatin and somatostatin analogs do that are important in carcinoid tumors. It decreases diarrhea and stool output, decreases gut hormone secretions. It slows the gastrointestinal transit time. Patients with carcinoid have a dramatically increased gastrointestinal time, and we documented that in another paper we published in the New England Journal of Medicine. Mouth to anus transit time may be as little as just 4 to 6 hours, and in most of us, normally it should be 24 to 48 hours. So it dramatically slows that, and that's one of the reasons that diarrhea gets better, and it enhances water and electrolyte absorption. Octreotide, named that because it's an 8 amino acid peptide, is a synthetic version of naturally occurring somatostatin, which is a 14 amino acid. The synthetic version has the same structure that I like to point out, has a hairpin turn, and the 4 amino acids shown at the right side of the screen are the 4 amino acids that bind to the somatostatin receptor. And you've heard that 80 to 90% of carcinoid and pancreatic neuroendocrine tumors have these receptors. We exploit that because we can give octreotide by subcutaneous injection, and it has a half-life of about 2 hours. This naturally occurring somatostatin has a half-life of 2 minutes, so it was really not useful therapeutically. But the synthetic analog is, and we showed early on that you could dramatically improve the symptoms of flushing and diarrhea, and also improve symptoms related to insulinomas, glucagonomas, and vipomas by giving 3 shots a day. This happened because of the anti-secretory effect. It decreased the production of the hormones that mediate these syndromes, and we saw hormonal responses in about 72% of our patients. Other colleagues around the world have corroborated those findings with symptomatic responses occurring in anywhere from 60 to nearly 90% of cases, and that's associated with symptomatic improvement. So this is the anti-secretory effect, and I'm differentiating that from the anti-proliferative effect, which we'll come to shortly. So I mentioned that the first paper we published was just 25 patients, but subsequently we published results in 66 patients, and this is really the data that Sandoz at that time used when they went to the FDA to get the drug approved. Just 4 years after we had started the initial clinical trials in 1984, they got approval in 1988. In those 66 patients, we saw flushing improve in nearly 90%. It was completely controlled, as shown in yellow, in nearly 60%, and diarrhea decreased by 50% or more in 3/4 of the patients, and completely normal bowel movements were seen in a third of patients. The metabolite of serotonin, called 5-hydroxyindoleacetic acid, or 5-HIAA, is the most accurate way to monitor serotonin production. We find it far more accurate than measuring serum serotonin. And disadvantage is it does require a 24-hour urine collection, but I've done this in thousands of patients, and it certainly can be done. So for about 10 years, all we had was the octreotide given 3 times daily by subcutaneous injection. But then Sandoz developed a new product called octreotide LAR. LAR stands for long-acting release. And this is a depot formulation which can be given deep intramuscularly into the buttock, largest muscle in our body. And it's slowly released over a 4-week period of time. The dose and frequency can be adjusted for symptom control. Usually we'll start with 20 or 30 milligrams of the Sandostatin LAR. If it lasts for a full month, as it does in most patients, we'll just continue at 28-day intervals. But then individual adjustments are important. If a patient comes back and they've been on 20 milligrams every 28 days and they say, "Doc, I'm fine, I don't have any diarrhea, I can go out and have fun with my friends until that week before my next shot. And then I find I'm having a lot of breakthrough diarrhea. What am I going to do with that patient?" Well, I'm going to consider changing the dose frequency from every 28 days to every 21 days. If they come back and say, "Doc, I'm better, but I'm still having some problem controlling my bowel movements, I still have to wear pads so I don't soil myself," I'm going to go from 20 to 30 milligrams. And it's outside of the so-called package insert, but we have a low threshold and a large experience going to higher doses, namely 40 milligrams and 60 milligrams every 28 to every 21 days, although Medicare has just started to crack down on those doses in the U.S., in New Jersey, and in Texas, and it's probably going to start happening in other states as well. Walter, do you have any trouble giving doses higher than 30 milligrams and getting the government to pay for it here?
No, not so far.
Okay, good. Keep it under the table. Are any of you in the audience on doses higher than 30 milligrams every 4 weeks? Okay. Well, the good news there is that there's room for dose escalation if any of the rest of you are on 30 and have trouble in months or years to come. So the currently accepted indications for octreotide are those people who have symptoms related to the elevated levels of the serotonin, in patients whose disease may have been stable. They've got metastatic disease that may have been stable for several years, but now there's evidence of progression, even if they don't have a carcinoid syndrome. Not all carcinoid tumors produce serotonin or substance P, but progression of metastatic disease, for me, is a trigger to start Sandostatin therapy because we now know it does have an anti-proliferative effect. And importantly, even in patients who are on Sandostatin LAR, it can be used before procedures like dental extraction, hepatic artery embolization, liver surgery, intestinal surgery, or even more minor procedures that have nothing to do with the abdomen, such as total knee replacement, total hip replacement. I shouldn't call those minor, but they're not in the GI tract. Any stress such as surgery can precipitate a carcinoid crisis, and so we routinely pre-medicate our patients with an immediate release form of octreotide at the dose level of 500 to 1,000 micrograms 30 minutes before the procedure. Now, we talked about the anti-secretory effect. I showed you how commonly it lowers the circulating levels of serotonin and other hormones. And I'm going to talk about the anti-proliferative effect of octreotide separately. Previous studies demonstrated tumor stabilization and partial regression of tumors in a small subset of patients. And this is a summary from the literature. It really is a small subset, as you can see under the column CR/PR. That stands for complete response and partial response. And in these 4 separate studies, if we summarize them all, only 4 patients out of 167 had significant tumor shrinkage. It happens, but it's rare. More often, we see disease that has been previously progressive become stable. And that's what's meant by SD, and you see that stable disease occurs in 44% of cases. PROMID is an acronym that stands for Prospective Randomized Trial of Octreotide in Mid-Gut Carcinoids. So physicians are just as big on acronyms as the government. Everything has to have an acronym. This was an interesting trial because for many of us, we had the clinical impression that patients who were progressing and then put on octreotide often developed disease stability that ranged from many months to a few years. But we didn't have hardcore scientific proof. A group in Germany led by Rinke and Rudy Arnold got colleagues at 14 different major centers across the country of Germany to participate in a multi-center clinical trial. And this trial took patients who had just been diagnosed with carcinoid from the small intestine, metastatic to the liver, and they randomized them after telling the patient what was going on to either receive placebo injections of saline into the buttock muscle or injections of octreotide sandostatin LAR 30 milligrams. And they got the placebo or the sandostatin LAR every 28 days. And every 3 months, patients in both groups were subjected to a CT scan or an MRI scan. This was double-blind, meaning that the patient didn't know if they were getting the real drug or the placebo, and the physician didn't know if they were getting the real drug or placebo. And the CT and MRI scans were read by a central reader. What happened? So the results were really very interesting. Again, this was randomized placebo versus active drug. And when the data was analyzed, the 42 patients who had been on octreotide had a median time of 14 months until the tumor progressed, and those who were on placebo, still being followed the same interval every 3 months, had a median time to progression of 6 months. So the time to progression was 2.5 times longer in those on octreotide therapy. It worked even better in the patients with a low hepatic tumor load. In this study, they were stratified according to whether they had less than 10% of their liver involved or 10 to 50% and greater than 50% of the liver involved with tumor. And the patients who had the lowest tumor burden had the longest time to progression, 27 months, versus 7 months for those with greater than 10% tumor burden. So the message here is that treatment early before there's a high tumor burden is very advantageous compared to waiting until 90% of the liver is replaced by carcinoid. So the prognostic factors for time to progression in these carcinoid patients was seen whether the tumors were making serotonin or not. It was seen whether or not there was elevated levels of chromogranin A. And the most favorable treatment outcome, as I just showed you, was seen in patients with a low tumor burden. I'm going to skip that and just touch on octreotide plus RAD-001, which is the new compound that just got approved. Generic name is everolimus, and the brand name is Afinitor. It's already approved in the U.S. and I think in Canada for renal cell cancer, and just got approved this last month for pancreatic neuroendocrine tumors. What does RAD-001 do? Well, it inhibits the mTOR pathway, which is showed with the pulsating yellow circle around it. And the mTOR pathway is critical for cell proliferation and regulates vascular endothelial growth factor and gene transcription. So when you inhibit that, you get reduced growth of the cancer cell. Circled in yellow is a tumor that is one of my patients with a carcinoid that actually originated in the kidney, and I had no other options for him at that time when he progressed, so I sent him to James Yao in Houston, who had a phase 1 trial of RAD going on, and you can see the significant tumor regression that occurred when you compare the right panel to the left panel. We published this trial about a year ago, and this involved the use of this drug in patients with pancreatic neuroendocrine tumors after they had failed at least one course of cytotoxic therapy. And what we saw was that this was not a randomized study, but patients who had been on chemotherapy, and they had to have been before they were eligible, but they were on sandostatin, could stay on sandostatin, but they got RAD-001 added in the lower half of the slide, and those who were just progressing actually got RAD-001. The results here show that we do not have objective tumor regression very frequently, only about 8% of those getting RAD-001 and 4.5% of those getting RAD plus sandostatin. But this is what's called a waterfall plot, and the columns below the ordinate labeled 0 are patients who had some degree of tumor shrinkage, and the magnitude of that tumor shrinkage is showing on the panel. In order to meet the criteria for a partial response, the tumor had to shrink by greater than 30%, and it was considered progression if it increased more than 20%. So you can see that tumor shrinkage to qualify for a partial response is not common, but the majority of these patients had some degree of tumor shrinkage. And stability of disease was seen in about 70 to 80% of patients who had, by definition, progressive disease when they went on. So this will be an important addition to our therapeutic armamentarium. And if it gets approved in the U.S., approval in Canada will probably follow very shortly thereafter. We saw that the patients in that study who were getting RAD plus octreotide had a much more favorable outcome in terms of progression-free survival than those getting RAD alone. And the overall survival also appeared to be better in those getting RAD plus octreotide versus RAD alone. So another important trial that was just published in the New England Journal of Medicine within the last 6 weeks and was really the basis for the FDA granting approval last month was this so-called RADIANT 3 trial. First trial I showed you was RADIANT 1. RADIANT 3 actually involved more than 400 patients. These patients had to have disease progression, but in fact they did not have to have prior chemotherapy. And they were randomly assigned to everolimus versus placebo, again double blind. And what we saw is summarized here. The patients on the active drug had a significant improvement in the time to progression, the progression-free survival of 11 months shown in red versus only 4.6 months in the placebo arm. So this is highly statistical significant, and this was the basis for the FDA's approval. So everolimus resulted in a significant 6.4-month increase in median progression-free survival, provided a 65% reduction in risk of progression. It has a very acceptable safety profile, which I can discuss during the question and answer session if you like, and it showed a consistent benefit in all subgroups, regardless of whether somatostatin analog therapy was also being given. I think my time is up, and happily there was a nice presentation this morning that you heard about peptide receptor radiotherapy. We are going to start therapy in the U.S. and I hope in Canada, if colleagues here will agree to participate. Within the year, a very small company called Biosynthema had the patent rights to this lutetium octreotate compound, but now that's been acquired by a company in Italy called AAA, Advanced Accelerator Applications, and they're going to infuse the $20 million necessary to do these randomized trials that we hope to start at select centers in Canada and at select centers in the U.S., hopefully by year's end. It'll be a randomized study in which patients with progressive disease will be randomly assigned to get higher doses of sandostatin versus lutate therapy. With that note, I'd like to stop and be happy to answer questions with the rest of the participants. Thank you all very much.